Thank you very much for the kind invitation, and it's wonderful to be here. I thought I would start with a really quick story. I got in the cab in the airport to come to your lovely city, Stavanger, which I've been practicing. And I engaged in discussion with the cab driver, and he said, "Oh, American, huh?" And I said, "I didn't vote for him." And he said, "Thank you." He said, "God bless." Right. So I actually changed my talk title a little bit from yesterday because several folks in the previous audience came up and asked about our clinical trials. So I'm going to take a little deeper dive into what we're doing in Boston with the clinical trial in ME and long COVID. Here's a table of contents about what I hope to talk to you about. Our major vehicle for investigating exercise intolerance in ME and long COVID is what we call the invasive cardiopulmonary exercise test. And many in the audience may know about the non-invasive variety. The invasive one involves 2 catheters. I'll show you a quick video on that. It allows us a very deep dive into the physiology of the patient that we can't get, at least with current methods and biomarkers, without the catheters. I'll begin by telling you a little bit about that. This is an individual cycling in the basement of our hospital. We do about 14 of these a week for various reasons. About half of them are for things like heart failure and pulmonary hypertension, but as you'll learn, this has proven extremely useful in better understanding exercise intolerance in ME and long COVID. So this gentleman is exercising with a mouthpiece. There's a pneumotachograph. It measures ventilation. It measures pulmonary gas exchange. And then the 2 catheters are here, a pulmonary artery catheter and a radial artery catheter, and I'll show you what we get from that. This is sort of a somewhat simplified version of the diagnostic algorithm, and most of this I'm not going to talk about. Up here is an assessment about how impaired your patient is, the VO2 peak, that's from the mouthpiece, and the metabolic cart, it's a non-invasive variable. This too is a non-invasive variable. We can rule out a lung limit to exercise. And then with the help of the pulmonary artery and the radial artery catheter, we can deduce whether the patient has a pump problem, the cardiac limit. We can determine whether it's left heart disease or right heart disease. But as you'll see in the course of this next 10 minutes or so, where our patients with ME and long COVID, unless they have fibrotic lung disease or a cardiomyopathy or a blood clot, end up in these 2 buckets, and I'm going to end up coming back to these. So I want to introduce to you the 2 major findings that we have found with this type of testing. One is something we call preload failure. In English, I can't do the Norwegian. In English, this is failure to prime the pump. It's failure to move blood appropriately out of the legs and the abdomen in the upright position up to the right heart so it can do its thing. We call it preload failure, and I'll show you a little bit of that. The other one is a phenomenon that we have discovered on the arterial side. So imagine blood coming back from the legs with upright exercise, and the pump is trying to do its job, and it gets blood out the aorta. And if all things are right, all that blood flow, or 80% of it at peak exercise, will be directed appropriately to the exercising limb, skeletal muscle, and even better yet, to where the mitochondria are in the small fiber of the leg, the exercising leg. So we've identified an abnormality that is consistent with blood flow abnormalities in the leg, meaning blood is not getting to the mitochondrion, and or something Rob Voost is going to talk to you about in the next talk, which is an intrinsic mitochondrial problem. So to summarize these 2 findings, preload failure and poor oxygen extraction on the arterial side, I'll refer to one paper that we published back in 2021. We have more recent data on this as well. So there are 2 extremes of these abnormalities that result in a low VO2 peak and presumably symptoms, and that includes fatigue, lightheadedness, shortness of breath, etc. One is the low flow state. This is cardiac output. So if the cardiac output at peak exercise is down, got a low flow state, and we find that roughly a third of the time as the sole abnormality. The other abnormality that we find I just alluded to, this is out on the arterial side. I should say in passing quickly, we've had this discussion. Most of the patients, in fact, the overwhelming majority of patients I see do not have a problem with arterial oxygenation, even if the pulse oximeter tells you there is. That's a fake out. It's vascular in origin. The problem is the failure to take up and utilize oxygen that's been delivered to the periphery, and that's this other subset. Poor oxygen extraction is shown over here, and we identify it during our testing with a lot of cardiac output, which in our world is pulmonary blood flow. This is blood going through the lungs and a low VO2 peak. So it's what we call a high flow state. But that cardiac output is going around and around in the pulmonary circuit, and it's ineffectual. It's not getting to the mitochondrion properly, and or the mitochondrion is not picking it up properly. This is our recent work on this. We're about to present it in a week in San Francisco at our lung meeting, the American Thoracic Society. What we've got is basically a larger cohort, twice the one I just showed you, 335 patients with ME, 72 with long COVID, and a cadre of normal controls. And what you can see is that the VO2 peak is similarly depressed in both of these diseases. The reason it's depressed is that the cardiac output at peak exercise is depressed, again, in a similar fashion to both diseases. The reason the cardiac output is down is preload failure. This is the right atrial pressure at peak exercise. And then there is an equal prevalence, at least across the board, of impaired systemic oxygen extraction. So it's the same thing that I've shown you with the prior work, with an expanded database now, including a relatively large cohort of long COVID. In the exercise world, ME and long COVID are frighteningly similar, if not identical. So this is where they end up in our bucket. I'll point out that many of the VO2 peaks are a little bit better preserved. Don't write them off. If you've done a non-invasive CPET and the VO2 peak is 90%, there still may be these abnormalities underlying all of that. So these are the two big vascular findings that we have found. On the venous side, Envision lacks veins. They're not squeezing down properly. They're not priming the pump. And on the arterial side, we've got a problem with systemic oxygen extraction. I want to add this one because this is something we're keenly interested in and may underlie the pathophysiology of some of the exercise intolerance in both ME and long COVID. And it's been described in both of those diseases. It's called small fiber neuropathy. So for those of you unfamiliar with the small fibers, they've been known forever to mediate nociception or pain. The diagnosis is made by a skin biopsy, interestingly, and demonstrating that with special staining, the neurites, these unmyelinated neurites in the epidermis, or innervating the sweat glands, probably even better, are deficient. The ones that remain, though, are dysfunctional, and pain is often manifested in the form of fibromyalgia. What's been more recently appreciated is that there is an autonomic function to these small fibers. They play a role in a lot of things, including vascular tone. So they've been associated in the entity postural orthostatic tachycardia syndrome. It's been a 40+% prevalence in both of these diseases, fibromyalgia, and then this form of dysautonomia. These small fiber nerves disappear in settings of inflammation. One is diabetes and inflammation, but they're also commonly deficient in connective tissue disease. And our hypothesis is that autoimmunity and inflammation in ME and long COVID may drive some of this phenomenon. So what we have found in this new cohort that we're about to present partially at ATS in San Francisco and hopefully in Amsterdam this September is that there is about a 2/3 prevalence of small fiber neuropathy in ME and long COVID, and we're inclined to think that it drives some of the vascular abnormalities during exercise that I just told you about. So now to our clinical trial. We've got two drugs. I think I've just made a case perhaps for a neuroactive drug, which is pyridostigmine, also known as Mestinon. It's FDA approved in our land for myasthenia gravis. It's known to increase acetylcholine, a neurotransmitter in the neural synapse. This is an off-label comment, as will be the other drug that I'm about to talk about. We think it works in dysautonomia, autonomic nervous system dysfunction, POTS, and the preload failure here at the sympathetic ganglion, which is a cholinergic step. So it enhances the amount of acetylcholine right here, and then the subsequent postganglionic fiber is sympathetic and can regulate blood vessel tone. So how do I know any of this is going on? We did a prospective study using the invasive CPET. We had patients with ME-CFS pedal away. We identified the preload failure. They received half of them, one dose of pyridostigmine, 60 milligrams by mouth, and the other half got placebo, and then they pedaled again 45 minutes later. And what we saw is if they got drug, their VO2 peak at the end of the exercise bout was better. If they didn't, it was worse. The reason that the VO2 peak was higher was cardiac output, and the reason the cardiac output was higher was improved preload failure. So we think this line of evidence suggests that dysautonomia is playing a role in some of the vascular abnormalities, including preload failure. So we are using that drug in our clinical trial I'm about to tell you about. The other drug we're using is familiar to Scandinavia, because that's where we borrowed it from, low-dose naltrexone. I won't go into all this, but largely it's thought to be anti-inflammatory. At the same time, it does not immunosuppress patients. It actually restores natural killer cell function in both ME and long COVID. So it's attractive, and it's somewhat of a pain receptor and agonist, an opiate agonist, so it can help with fibromyalgia as well. That's been shown in retrospective studies, and we think exercise intolerance may improve as well. So we are using these two drugs in what we call the LIFT study at Harvard. So this is the Open Medicine Foundation funded study at the Brigham and Women's Hospital where I work. We're taking all comers with ME and long COVID who meet Canadian consensus criteria. That includes the long COVID folks. We screen them. It's going to be 4 arms, 40 patients in each arm. Patients in one arm get a combination of Mestinon and low-dose naltrexone. Another gets just the Mestinon or pyridostigmine. The other gets just the low-dose naltrexone, and there's a placebo arm and a 1-to-1-to-1 ratio. We have a variety of outcomes. This is our dosing regimen. I've been asked several times, how do we use Mestinon? We target 60 milligrams 3 times a day, and that's what we escalate to. And the low-dose naltrexone, we start out at 1.5, and then we end up at 4.5 after a couple of weeks. So this is where they end up. And we study them for 3 months. We have outcomes, in part a wearable device. This is a Garmin Vivo Smart that measures a bunch of physiologic variables that will be worn continuously. We have a bunch of omics, including proteomics at the beginning of the study, and at 3 months out, metabolomics, peripheral blood mononuclear cells, and added on more recently transcriptomics. We have got what you have heard about with FunCap. We're very excited to have a variety of well-validated, but especially FunCap questionnaires that are administered at the beginning, at the end, and in the middle of the study. And then finally, we've got something called a SHAPE test. This is a non-invasive cardiopulmonary exercise test. It is well tolerated by patients. Now, I should emphasize the patients need to be able to come into the office and do the study. They can't be bedridden or at home, sadly. So these are moderately affected folks. But we hope to learn and extrapolate to the more severely affected folks. So it's an upright test, but they get to hang on here, and we monitor their symptoms. If there's any orthostatic intolerance, we can slow down. It's paced. It's one of our exercise physiologists. She's going fast. It's self-paced. There's a metabolic card. It gives us many of the measurements that the non-invasive cycling test gives. We do this physiologic study at the beginning and at the end of our study. So I want to thank you for your attention. You've got a lovely place here, and it's been my pleasure to be here. Thank you.